Hello, everybody. Are you hearing me?
Hello.
Okay, let me start today's session. Welcome to IMA pre-conference CME series. We will have four CME sessions in 2 days, within 2 days. So we begin the first session today. It's titled as seeing the future AI for diabetic retinopathy screening. The moderator of this CME session is Dr. Jibat Gameda. I'll introduce you, Dr. Jibat Gameda, and we'll continue today's CME session. Dr. Jibat Gameda is a medical doctor. Is a prominent vitreoretinal and retinopathy of premature or ROP and cataract subspecialist in Addis Ababa, Ethiopia. He serves as chief ophthalmologist and subspecialist at Mulie to Comprehensive Specialist Hospital since 2023, with joint roles at MCM Hospital, Siyum Specialized Eye Clinic, and Dalia Specialized Eye Clinic. Previously, he was assistant professor of ophthalmology at Haramaya University since 2019 to 2022, and is earning a certificate of completion in ophthalmology for developing countries from Shenyang Normal University in collaboration with Eye Hospital, Shenyang, China, since September 2024. He also holds certification in Global Eye Health, London School of Hygiene and Tropical Medicine since 2021, and hands-on training with Orbis Flying Eye Hospital, specializing in retinal disease, surgical innovations, and laser therapies management, cataract surgery. And Dr. Jibat has published in journals like Journal of Ophthalmology and BMC Health Service research with over 13 citations. So I will give him the podium for Dr. Jibat to moderate today's CMC session. Thank you.
Okay, thank you, Murugeta. Do you listen me? Do you hear me?
Yes, we can hear you, Noti.
Okay. Okay, good morning, everyone. Our today's session is organized by Ethiopian Medical Association and Ophthalmologic Society of Ethiopia. Our CMC session title is Seeing the Future AI for Diabetic Retinopathy Screening. Before introducing our today's speaker, I will say something about the burden of diabetic retinopathy worldwide and here in Ethiopia. So worldwide, more than 500 million populations are living with diabetes. From those population, 1/3 has some form of diabetic retinopathy, and 10% of them has either visual impairment or they are blind. So if you see the burden, particularly in sub-Saharan Africa, the burden is high, where screening and treatment is limited. Here in Ethiopia, around 20% of people living with diabetes, they have some form of diabetic retinopathy. So today's session will explore how AI can help us expand access to diabetic retinopathy screening, and so that we prevent avoidable blindness here in Ethiopia. So it is my pleasure to moderate this session, and I would like to introduce our today's speaker, Dr. Destaw Mulie. He is a vitreoretinal and phaco subspecialist currently working at Waga Eye Center. He he earned his medical doctor and specialty of certificate in ophthalmology from University of Gondar, where he later served as a lecturer, ophthalmology resident, and assistant professor of ophthalmology at the Tertiary Eye Center. He's also a fellow of the International Council of Ophthalmology, FICO. So he did his fellowship, long-term fellowship at the prestigious Eye Institute, one of the top eye institute in India, at the LV Prasad Eye Institute, and he also did another training in advanced phaco training at Nanda Deep Eye Hospital. In addition, he served as assistant professor and honorary staff of St. Paul Millennium Medical College with significant contribution in surgical expertise. Dr. Destaw has performed over 2,600 phaco emulsification, most of them under topical anesthesia, which is one of the first who started topical anesthesia for cataract surgery. And he did also complex vitreoretinal surgery as well. His special interests include aphakia management, pupilloplasty, iridodialysis repair, retinopathy of prematurity, medical, surgical, macular surgeries, and medical retina. He is an active member of Ophthalmology Society of Ethiopia, American Academy of Ophthalmology, and African Retina Society. So, Dr. Destaw, the floor is for you.
Thank you, Dr. Jibat, for the kind introduction. So, I will be talking on the role of AI for diabetic retinopathy screening. Here are the outline of my presentation. So, I'll brief you with the basic anatomy of the eye, which is relevant to our topic of discussion, and we'll see the burden of diabetic retinopathy worldwide in Africa.
Sorry, Dr. Destaw, could you share your slide, please?
Is it visible now?
No, it's not visible.
Okay. Just a moment. Are my slides
now visible? Just
am I audible?
Make it full slide, yes.
Thank you, Dr. Jawad, for the kind introduction. So today I will be talking on the role of AI for diabetic retinopathy screening. This is the outline of my presentation. I'll brief you with the basic anatomy of the eyeball, which is relevant to our topic of discussion. We'll see the burden of diabetic retinopathy, and we'll try to cover the available diabetic retinopathy screening methods, and mainly we'll focus on the role of AI for diabetic retinopathy screening, and also we will see the AI in diabetic retinopathy screening, what we have done in Ethiopia so far, and we'll try to see the limitations. And to start with, I am sure many of you have sent patients to ophthalmologists for funduscopy examination. So what is ocular fundus? Ocular fundus is just the inner side of the eyeball. As you can see, this is the ocular fundus, which includes the optic nerve, the retinal blood vessels, the macula, and the peripheral retina. The optic nerve is this is the optic nerve. So this picture is showing the retina. So this is the optic nerve, and which is a round, slightly oval structure with pinkish hue and clear demarcation. And out of this optic nerve rises the central retinal artery and vein. So this is the central retinal vein, which is more dark shade, and central retinal artery is light red, and this one. And so from this optic nerve, these arteries branch to different quadrants of the retina: the superior nasal, superior-temporal, inferior-nasal, and inferior-temporal. Normally the optic nerve is located nasally, and by seeing the optic nerve we can make out that this picture is the fundus photo of the right eye. And then there is also the macula, which is between the superior and inferior vascular arcades. Inside the macula there is an area called fovea, which gives clear vision, which is responsible for clear vision. And normally the fundus of patients have different variants depending on the pigmentation of the individual and also the choroidal vascular network. As you can see, all these 4 pictures are of normal variants. And this picture is showing the fundus photo of the right eye and the left eye. Like this is the optic nerve, this is the macula, and this is a montage picture showing all quadrants of the retina, the posterior part and the anterior part of the retina. And with this, what is diabetic retinopathy? It's one of the microvascular end organ damage of the retina, which is due to diabetes mellitus, and it is the most common microvascular complication of diabetes. I'll take you through the International Diabetes Federation Atlas of 2024. This atlas is showing a staggering nature of the prevalence of diabetes all over the world. As you can see, there are about 589 million adults aged from 20 to 79 who are having diabetes. Of this, for those like in the population from age 20 to 79, one out of 9 people is diabetic, and unfortunately 4 out of 5 adults, and this is showing also unfortunately 4 out of 5 adults with diabetes, which translates to 81%, are living in the low and the middle income countries. Overall, if you see the economic impact of diabetes in 2024, over 1 trillion USD was spent for the care of diabetes. And when we see the burden of diabetes, the global epidemic is expected to affect around 640 million individuals by year 2040. And as it was clearly mentioned by the moderator, 1/3 of the diabetic patients are estimated to have diabetic retinopathy. Of that, 1/3 of this group is likely to have vision-threatening diabetic retinopathy. Diabetic retinopathy stands as the leading cause of new onset blindness among the working age group. Studies have revealed that 73% of patients who have actual diabetic retinopathy, they don't realize that they have diabetic retinopathy. That means most of the patients are asymptomatic. 73% of patients are asymptomatic. Approximately half of the patients living with diabetes, they remain undiagnosed, and this results in significant delay in critical ophthalmologic intervention. Among diabetes patients globally, it estimates that 1/3 of them suffer from diabetic retinopathy, which is explained. If you see the magnitude of diabetic retinopathy in Africa, out of 1 million people, which translate in this the working age group, out of 1 million, it's 500,000. Of this, if you see those patients who are affected by diabetes due to vision-threatening diabetic retinopathy, which is 10%, it translates to 2,350 people out of 1 million. And a systematic review in Ethiopia on the burden of diabetic retinopathy has shown that the epidemiological situation in Ethiopia reflects concerning trends, and the prevalence of diabetes in Ethiopia is from 2 to 6.5%. So 2 to 6.5%. This translates to millions of patients in Ethiopia. And recent studies report the prevalence of diabetic retinopathy around 19.48% among Ethiopian diabetic patients. And we have obviously a very small number of ophthalmologists, not more than 200. And with this, I'll take you to the classification of diabetic retinopathy. The most common way of classifying diabetic retinopathy is the International Clinical Diabetic Retinopathy Severity Scale, where it classifies diabetic retinopathy into one is where there is no disease, so that means no diabetic retinopathy, and there is mild non-proliferative diabetic retinopathy, and there is moderate, and there is severe, and there is also the advanced form of diabetic retinopathy, which is proliferative diabetic retinopathy. Mild, moderate, severe, and proliferative. Okay, so some of the clinical pictures that we see from in patients with diabetic retinopathy is microaneurysms, which is the earliest sign. They appear as small round dots. As you can see on this picture, these small round dots are microaneurysms, and this is the corresponding fundus autofluorescence image, which is hyperfluorescent. And the other clinical picture of diabetic retinopathy, patients present with retinal hemorrhage of different types. That could be flame-shaped hemorrhage, which is usually superficial, or it could be dot and blot hemorrhage. Patients can have those patients can have with macular edema, or they may not have macular edema. So macular edema can be classified as center involving and non-center involving. So patients of any from mild to proliferative diabetic retinopathy, they can have associated macular edema or may not have macular edema. So these are this picture is showing some hard exudates, which are leakage which shows yellowish deposits due to leakage from the vessels, and these soft exudates are mainly superficial one that shows the infarction or swelling of the nerve fiber layer. And patients can this non-proliferative proliferative diabetic retinopathy patients usually they present with new vessels which are not normal. So these vessels could be new vessels at the disc that we call NVD, and new vessels elsewhere outside the disc. And this is a picture showing more advanced diabetic retinopathy having pre-retinal hemorrhage and obliterated vessels. And this is also the most advanced form of diabetic retinopathy, tractional. As you can see, the retina is lifted, and we call this tractional retinal detachment. Diabetic retinopathy can also cause secondary glaucoma in the form of neovascular glaucoma. So why do we need to screen diabetic retinopathy? According to the Wilson and Jenger principle of screening, there are certain conditions that has to be there for the disease to be screened. So diabetic retinopathy, as we have been discussing, is a major public health problem, and most of the patients are asymptomatic. And if you get the patients timely, the blindness can be or vision loss can be avoided, and there is a clear treatment guideline for those patients with diabetic retinopathy. That's why we need to screen diabetic retinopathy. And the aim of diabetic retinopathy screening is to reduce the risk of vision loss, vision impairment, and blindness among asymptomatic patients, which accounts for 73% of the patients, as we have mentioned. So here I will just I want to focus on the diabetic retinopathy screening criteria. So it depends on the type of diabetes itself. So for the type 1 diabetes, the screening should be within 5 years from the diagnosis. And for type 2, the screening should be at the time of diagnosis. This you should not forget. Type 1 in 5 years from diagnosis, type 2 at the time of diagnosis. And for those diabetic patients who are pregnant, the diabetic retinopathy screening should be done, and first retina exam should be done after conception, immediately after conception, or early in the first trimester. But for those patients without any previous diabetes mellitus, you don't need to screen the gestational diabetes mellitus. So that doesn't require screening unless they have previous. The ICO guideline states that adequate diabetic retinopathy screening should include visual acuity exam and retinal examination. So what's adequate retinal examination? It includes at least one of the following. So either there should be direct or indirect ophthalmoscopy or slit lamp biomicroscopic examination should be done in the clinics, or there should be retinal photography. So one of these should be there. So if you see the screening rates, only 62.3% of patients with diabetes in the United States receive annual screening. So even in developed countries like United States, the annual screening rate is very less, and this could be attributed due to different causes: low income, low educational status, minorities, recent immigration, for different reasons, and lack of insurance can also contribute. So regarding the re-examination and referral recommendation based on the international classification of diabetic retinopathy and diabetic macular edema, there are two recommendations. One is for the high resource setting, and one is for the low and middle income countries. So once you get the diabetic patient, if it depends on the classification, and when you the re-examination and referral to the ophthalmologist depends on the classification of the diabetic retinopathy. If there is no apparent diabetic retinopathy, or if it is mild non-proliferative diabetic retinopathy, you don't need to refer this to the ophthalmologist, okay? And then you can re-examine the patient in 1 or 2 years. And for those patients who have more than moderate non-proliferative diabetic retinopathy, it should be referred. And for high resource settings, and any type of macular edema should be referred. And for low and intermediate resource settings, the referral for ophthalmologists is from moderate non-proliferative diabetic retinopathy. Okay, if it is no diabetic retinopathy or mild, then you don't need to refer. And again, the difference in low and high resource settings in regards to the diabetic macular edema is, if it is non-centered diabetic macular edema, referral is not required in low and intermediate resource settings. So what are the available tools for screening? I'm sure most of you know this direct ophthalmoscope. This is the oldest way of screening diabetic retinopathy, which is, so you use a direct ophthalmoscope, which is a small device, mobile, relatively inexpensive. And the other way of screening is indirect ophthalmoscopy, which is most commonly used by retina surgeons. It's mobile. It shows you large field of retina that can be examined, and relatively is inexpensive. So it requires obviously dilation. The drawback of indirect ophthalmoscopy, the drawback is, am I audible?
Yes, you're audible.
Yes, Dr. Destaw.
Thank you. So the drawback of indirect ophthalmoscopy is it requires pupil dilation, and there is no ability to audit retrospectively, because you just see once and there is no fundus image. That's why you can't audit. And the other way of screening is slit lamp biomicroscopy, which shows you large field of the retina, which is a gold standard for training health professionals in retina examination, and it also is relatively expensive. So the other way of screening is the retinal photography, which can be of mydriatic type or non-mydriatic type. So it gives you adequate field of retina available for examination, and this can be done by trained technicians. So these technicians need not to be eye care professionals. So some are portable and some are clinic based. So the advantage of retinal photography is that it's auditable, and it helps you to for objective comparison of the same patient's data on follow-up, and can be used for patient education or giving and the other, so it could be of requiring mydriatic drops, or it can be non-mydriatic. In mydriatic camera, in essence, you need to have pupil dilating agents. Usually these non-mydriatic cameras, they require no dilation in 80 to 90% of the time, but usually you need to use these tools in dark space. So the disadvantages is relatively expensive, and most importantly, in people with opacities, like media opacities due to cataract or different ophthalmic problems, this cannot be used. So that is the main drawback of fundus photo. Okay, if the patient is having some media opacity, then you will not be able to get clear picture, and that is one of the limitation. And ultra wide field imaging can also be used for screening, where you take a fundus photo, but this is a different type of fundus photo which shows the posterior and more peripheral part of the retina. As you can see, this white circle is showing this dots hemorrhages due to diabetic retinopathy. And the other and more famous way of diabetic retinopathy is teleophthalmology, where it's a cost-effective alternative to examination by ophthalmologists, whereby retinal images will be taken at on-site, and these images can be taken anywhere in the diabetic clinics or any low research setting, and this photo will be sent to another center where the ophthalmologist is sitting and grading. And studies have shown that it's teleophthalmology is comparative to when you see the sensitivity and specificity, it's more comparable with the grading of the ophthalmologist in clinics. And the image can be analyzed remotely by the ophthalmologist or any grader having training for the presence of any referable diabetic retinopathy, which means at least moderate diabetic retinopathy, as we have discussed before. So if there is referable diabetic retinopathy, then patient will be managed accordingly. Okay, in view of this teleretina. So what is the disadvantage of teleretina is patients may not take the reports on the same day, as they have to wait the grading by the clinician or the ophthalmologist. This takes us to the role of artificial intelligence for diabetic retinopathy screening. I'm sure many of you have heard about the machine learning, artificial intelligence, and deep learning. So what's the difference between deep learning and machine learning? It's just deep learning is the subset of machine learning, and machine learning is a subset of artificial intelligence, where a technique which enables machines to mimic human behavior is employed, and the machine learning is a subset of the AI technique which use statistical methods to enable machines to improve with experience. And deep learning is a subset of the machine learning, where the subset of machine learning which makes the computations of multi-layer neural networks are required. So why we use AI in diabetic retinopathy? So the advantage in ophthalmology is that most of the things that we are seeing in clinics can be documented, and where you can take photos. So it's image-based specialty, I can say. That's why we can easily integrate this AI for this screening. And there are also a shortage of eye care professionals, obviously. And if you see the burden of diabetes and diabetic retinopathy, we need to scale up the screening solutions. That's where AI comes into place. And obviously diabetic retinopathy is a leading cause of preventable blindness in the working age group. So basically, development of AI-based diagnostic system for diabetic retinopathy, it requires data to train the algorithm. So data in essence for diabetic retinopathy, I mean to say fundus photos. So we need fundus photos to train the AI algorithm, so that this algorithm can itself classify and show the performance of the AI system. So in the data there are training sets, validation sets, and testing set. When we say the training set, this is the fundus photos or whatever the data that you train, that you use for training the model, the AI model. And the validation is for fine-tuning of the algorithm. So it helps you which model is the best for the AI screening. So and the test is after once you develop the algorithm, a test is required. So it shows you the performance of the AI algorithm. How good is the test? That is by testing. Okay, out of the data that you have, like from 100% of the data like you have, you need to split the data, like 85%. 85% could be for training, and the remaining could be for the validation and test. Okay, here comes the image quality. When you are talking about the data, the image quality is very, very important. So there are certain criteria in order to assess the quality of the image. One is focus. Focus is just the detail. So how detail you can see, how clearly you can see the smallest lesions like the microaneurysms in the case of diabetic retinopathy, or even in normal fundus you have to be able to see smallest vessels around the fovea. So one is focus and the other is illumination. Illumination is just the brightness. There should not be, it should not be too dark or it should not be too light. And the other important thing regarding the quality of the image field definition. Basically, the image should have the macula and the optic disc, and there should be at least if you see this, there should be at least one disc diameter nasal to the image, and there should be at least one disc diameter away from the macula. That area should be there. Okay, that is the image field definition, and the presence of artifacts or not should be also considered. If you have these four criteria, good criteria, fulfilling all these four, then it could be quality could be graded as excellent, and two of these could be if 2 out of 4 is good, 1 out of 4 is adequate, and if it's not fulfilling all this, then the image can be classified as poor quality or non-gradable. If you, for example, if you take this picture, it's this excellent picture having all these features. In the second one, the centration or the image field is not good because the nasal part of the retina, one disc size, is not visible, and there is also clearly an artifact here. And on the side, the focus is very bad, and the illumination is very bad also. And also the temporally the area temporal to the macula is not visible. And this picture you cannot see the disc and the retinal blood vessels, so this is a poor quality picture. So poor quality pictures could be of different reasons. It could be eye abnormality associated with poor quality, or any artifact associated. So this is a picture demonstrating poor quality pictures due to different eye abnormalities. This one, like, it's because of cataract. This is because of, second is because of central retinal vein occlusion, so you can see the details of the retina clearly, and the third is because of the asteroid hyalosis in the vitreous cavity, and this in the last picture you can make out the optic disc clearly due to vitreous hemorrhage. There are online tools to grade the quality of the picture, as you can see. So what are the options to improve image quality? One is to recapture. Sometimes patients may not be cooperative, and sometimes the people, it might require dilation. So you need to you have to ask the patient to cooperate, or you might need dilating drops for clear picture. And there are also artificial methods to improve image quality, like contrast enhancement. And the other is basically when you take the pictures, instead of one field picture, ideally two field picture is very good. Two field in essence, one macula center where the center of, as you can see, the center of the picture is the macula, and here the disc center. So two pictures of the same eye. One is at the macula center, one is at this disc center. It will improve the quality of the image. So the other is image annotation. Image annotation is the tagging of the image, so that the ophthalmologist or trained person should grade the particular fundus photo according to the ICD classification. So whether that is no diabetic retinopathy, mild, moderate, severe, or proliferative, that image annotation should be done by ophthalmologists. And according to the Chinese guideline, at least 3 graders are required, and training this data set should have a minimum of 500 images which are non-readable, and there should be also some pictures having fundus photos having other disease patterns instead other than the diabetic retinopathy, in order to get a more predictable algorithm. So if you see the history of AI, McCarthy was the first the first one who proposed the concept of AI in 1956, and then Arthur Samuel. He talked about the concept of machine learning. And these three systems, the luminance score, digital diagnostics, IR system, and iHealth are the three FDA approved system, the American FDA approved AI algorithms for categorizing diabetic retinopathy. And the first one was in 2018. Here I would like to take your attention on this flow chart, where as you can see, let's say the patient, this is the patient, and this usually these are diabetic patients who could be in the endocrine centers or in the remote areas where there is no access to an ophthalmologist. So the patients, the diabetic patients will go to the clinic for routine diabetic care, and in these local clinics they take the fundus they take the fundus photo of the patient. This fundus photo can be taken by portable devices or bigger fundus photos like this. And this might require, during taking the picture, you might require dilation or not in order to enhance or improve the quality of the image. Once you take these photos can be taken by any technician, trained technician, and once you take the picture, then that picture will be uploaded to the cloud system of that that specific AI model. So that AI model will grade, the cloud will grade the fundus photo of the specific patient, and so if it is gradable, then so you have to decide whether it's referable or not. For example, if the patient doesn't have diabetic retinopathy, or if the patient is having only mild diabetic retinopathy, that the person who is working in that clinic will reappoint the patient in 1 or 2 years. But if the patient is having more than moderate diabetic retinopathy, then only or if there is centering polymacular edema, then only the referral for the ophthalmologist is required. If it is not gradable, if the fundus is not gradable, you need to repeat the imaging or you may use dilating drops. And if it is still ungradable due to different reasons, then you have to send the patient to the ophthalmologist if it's ungradable also, so as not to miss, because patients with cataract, you may not be able to take a good picture, and still that patient can have diabetic retinopathy and needs to be referred for the ophthalmologist. Okay, so the systems capture digital fundus photographs, typically non-mydriatic unless dilation is required, and you upload them to the cloud-based system as we have discussed, and it will generate the assessment whether it's more than mild, or whether there is vision-threatening diabetic retinopathy, or whether if it's not also gradable, then you have to send. So it's time saving. The Australian study found that the AI-based screening system for diabetic retinopathy only takes about 7 minutes in the endocrinology clinic. So AI systems enables patients to collect patients' fundus photos at a relatively nearby clinic. Sorry. So can be used to directly perform grading, receive further suggestions whether that patient particular needs follow-up or referral to the ophthalmologist. So it greatly reduced the workload of ophthalmologists, at the same time significantly improving patient care and compliance of diabetic patients. So what are the benefits of AI systems for diabetic retinopathy detection? So a study of 900 fully screened patients, which led to FDA clearance for the AI algorithm called the IDX-DR, showed that significant sensitivity of 7% and specificity of 90%. So it's accurate. The other is convenience and it's user friendly. So yeah, any technician can take fundus photo and upload to the AI system and decide whether that patient is referable or not. And the other is speed, as we have discussed. It takes only 7 minutes as per the study. And productivity, at least it improves the productivity of the HR by 50%. And access. We are talking about patients who are living in the low resource settings in the rural area or where there is no ophthalmologist. So by deploying AI systems, you can make diabetic retinopathy screening more accessible and prevent the risk of diabetic retinopathy related vision loss. So performance of AI for diabetic retinopathy, just like any system, there are this accuracy, precision, recall, F1, area under curve. These are parameters when you are talking about performance of diabetic retinopathy for AI for diabetic retinopathy. This takes us to the AI in diabetic retinopathy screening in Ethiopia. This was published by the Ethiopian AI team, which has also I'm also involved on this, where there are also ophthalmologists, and it's a knowledge distillation based lightweight mobile net model for diabetic retinopathy classification, which is published in 2025 recently. So our professional, the IT people, what they did is they developed the teacher model, and from that teacher model they use knowledge distillation technique, where they transfer the knowledge of the teacher model to the lightweight mobile net model, which can be applied and used in edge devices like mobile phones and portable fundus photos. So they developed the lightweight model which was very effective. And the methodology. So what we did was we take data sets in a sense, the fundus photos. So one we take from the Asian Pacific Teleophthalmology Society, which is APTOS 2019. It's one of the most widely used publicly available retinal fundus photo dataset, and it contains about 3,662 retinal fundus images with varying resolutions, varying quality. And it's collected from Aravind Eye Hospital, one of the famous eye hospitals in India. And the advantage of this online data source is that it was specifically designed for diabetic retinopathy screening. So we take online pictures to train our model, as well as we also take a primary data set in Ethiopia from the famous eye centers, including Waga Medical Service, Blue Vision Eye Care Center, and Nisr Eye Care Center. The fundus photos was taken by the Topcon fundus photo machines. The 3D OCT Maestro 2 was used in Waga and Nisr Eye Clinic, and in Blue Vision the fundus photo was taken by the DRI OCT Triton. So tens of thousands of pictures was taken from the three centers and selected, and annotation was done by two ophthalmologists. So this is the data set of the light. If you see, this is the light green from the online APTOS 19, and the primary data sets of different grades. It was that the fundus photo was graded as no diabetic retinopathy or non-proliferative diabetic retinopathy of any severity, which could be mild, moderate, or severe, and the other is proliferative diabetic retinopathy. So there are three classes. So the data set was set in such a way that three classes of data sets were made. So these are the representative pictures from our local data sets. The first picture is showing the healthy retina where there is no diabetic retinopathy, and the second picture is representative of non-proliferative diabetic retinopathy, and the third picture is the proliferative diabetic retinopathy. So in the data pre-processing, normally the fundus photos, in the fundus photo pictures, they come with the black at the corner. There is the black area, and this area was cropped this area was cropped and downscaled. The photo was downscaled in such a way that it will improve the quality, and it was changed to the RGB format with the splitting red, green, and blue format. And further quality enhancement was done by the CLHA model just to improve the contrast, and it was merged, and this is the ready fundus photo which was graded by the ophthalmologists. So if you see the when you come to the dataset, complete dataset, 85% of the dataset was used for training set, and the validation set, it's like training set was like around 72%, and the remaining 13% for validation set, and the rest of 15% of the data set was used to test the performance of the algorithm. In order further data further data augmentation was done. When data augmentation, in essence, if you see the original this picture, this is the original picture. In order to improve the generalization ability of the model, same picture was used at different rotation. Like this one is rotated, this is the original picture, this one is 90-degree rotated, this one is 270-degree rotated, and horizontal flip, vertical flip, and the cropped area of some, like this one is 80% cropped. So this is just to improve the generalization of the model to avoid overfitting. And this was the teacher representative picture of the teacher model and the student model. So first they developed the teacher model, and from this teacher model, having basically the CNN model has the input layer, the convolutional layer, the hidden layer, and the output layer. So the hidden layer was decreased, but in such a way that the performance is still as good as the teacher model. So the goal of the study was the goal of the project was to develop a lightweight CNN model which is applicable in small edge devices that can be deployed in rural settings where there is no ophthalmology. And this small edge devices, lightweight CNN models, they significantly reduce computational complexity and memory footprints, and is highly suitable for resource constrained devices. The experiment setup was done in specification of the Intel generation 13th generation Intel Core i7 with the TensorFlow Keras API TensorFlow. This is the interface on this specific setup. So they developed it on the TensorFlow framework version 2.1. And if you see the metrics of the teacher model and the student model, so so knowledge distillation, which is a process of transfer of knowledge of the teacher's model to the student or the proposed model, was used. And if you compare the metrics, their RAM usage, model disk size, computational complexity, the figures are clearly showing that the student model was developed with a very, as you can see the figures, very less size. And the model was checked for its performance as to classify whether there is diabetic retinopathy or no diabetic retinopathy. That's binary classification was used. So in the the performance of the developed AI model on the binary classification, that in a sense its ability to classify as no diabetic retinopathy versus diabetic retinopathy on different data sets. As you can see, this one, the upper picture, the up to 2019 data, the online data set, and the primary data set. This is the teacher's model. So the accuracy, precision, and the parameters are like it's more 99.45% in classifying whether there is diabetic retinopathy or not in the binary classification. And so that's the teacher's model is there, and the student model with knowledge distillation, which is the proposed model is there, and there is a student model without knowledge distillation. If you compare this the teacher model with student model, the outcome is comparative. It's an excellent outcome, which tells you that how good the performance of the model with knowledge distillation is, and it's all the same with the data for the local data set also. And the model was assessed for its ability to classify whether there is no diabetic retinopathy or any form of non-proliferative diabetic retinopathy, which could be mild, moderate, or severe, versus proliferative diabetic retinopathy. This is ternary classification. So there are three things here. One group is no diabetic retinopathy, the other group is non-proliferative, and the third is proliferative. So in this, the student model with knowledge distillation was compared against the teacher model, and the performance was amazing. As you can see, the accuracy, precision, and recall on the Aptos 2000 dataset and local dataset. Here the student model without knowledge distillation, the performance was less as compared to the student model with knowledge distillation. This tells you how good the process of knowledge distillation can improve this model. This is a comparison of our model with available state-of-the-art techniques. So in this, there are the trainable parameters. So the aim of this the model was to develop lightweight model. So if you see, for example, the Cheetah et al. They use like 66 million trainable parameters. Okay, and if you compare it with the the proposed model, student model with knowledge distillation, we used the 71,362 trainable parameters, significantly less. But again, then you can see the performance of this knowledge distillation model, student model, is having equal performance with the state-of-the-art techniques available. This is just the previous one is when we compare it with the state-of-the-art using the binary classification, and same is done. Same comparative was done using the ternary classification performance. So one of the limitations of machine learning models is that they are heavyweight, and our proposed model is lightweight model with comparable performance. Knowledge distillation has significantly impacted the transfer of knowledge from teacher's model to student model. So the good thing about this model is that it's really it's having really good performance on locally available data sets and also the Aptos online data set. So the study presented knowledge distillation techniques to transfer knowledge from the teacher model to the proposed student model, and it was evaluated for its performance, as I have said, on the Aptos 2019 model in primary data sets, demonstrating its robustness across different diverse data sets. As we have clearly mentioned, the comparison with the state-of-the-art techniques revealed that the proposed model achieves comparable performance while being significantly less resource intensive. And if you see the binary, its ability for binary internally classification, the performance is about 98.38% and 93% respectively. So this is all about the study we have done. If we see the general limitations of the AI algorithm, basically there is no unified standard for evaluating the validity of AI algorithm. So every AI algorithm, they use their own validity, so there is no standard validity for the fine-tuning of the algorithm. And the data sets also can be taken it can be taken from different fundus photo machines, or it can be taken from online source. So there is no uniform source of data set, and that is one of the challenge. In the standard photo, there are different ways of taking fundus photos, whether it's single field or two field photo, how much the periphery should be taken. All these things depends on it's variable. So that's one of the limitation. And then there's also that black box phenomena where the algorithm takes inputs, but in the hidden layer we don't know how we only know the output. We don't know the reality, what is inside, how the AI is working inside. So that the black box phenomena is also there. In most of the current studies, one of the limitations of the AI algorithm is that most of the AI algorithms currently available are used for one specific disease entity. So that's one of the limitation. And the medical legal considerations are also there. Whether this AI algorithm has to be registered as a medical device, and what if there is missing of the diagnosis of the patient, who is responsible for that? These are debatable things, and currently unclear how responsibility will be shared among clinicians, facilities, developers, and the regulatory bodies like FDA. And due diligence is also required. This is my reference, and I would like to thank you for your attention. Thank you.
Thank you, Dr. Destaw. So we have few questions from the participant, and I will raise for you, and you will react on them. Okay? So the first question is, do HIV patients with diabetes need more tight schedule for diabetic retinopathy screening? HIV and diabetic retinopathy.
So should I respond for this first?
Yeah.
Okay, thank you for the question. And I will say there is no such a thing. It's not the criteria for diabetic retinopathy screening is clearly mentioned, and how you refer is also mentioned. So it's there's nothing to do with HIV. One confusion here: if the patient is having HIV retinopathy, then the algorithm may take that picture as if it is caused by diabetes. So HIV retinopathy and diabetic retinopathy has some similar pictures. That is the only thing to be considered. Otherwise, the fact that the patient is having HIV has nothing to do with the schedule.
Yes, yeah. In HIV patients, the only thing is if the patient has both HIV retinopathy and diabetic retinopathy, they may need a tighter schedule. Otherwise, there is no separate agreed screening schedule. HIV retinopathy may worsen the future of diabetic retinopathy. Okay, next question is more clinical question. At what stage of diabetic retinopathy does intervention significantly change visual outcome? When do we intervene diabetic retinopathy?
Thank you. For intervention for diabetic retinopathy is mainly for vision threatening diabetic retinopathy. So there is a term called vision threatening diabetic retinopathy. So it could be due to macular edema or macular ischemia or proliferative diabetic retinopathy. So these patients with vision threatening diabetic retinopathy should be treated, and the outcome depends on whether you intervene on this stage. And regarding ophthalmologists should see referable case. In a sense, at least those patients with moderate diabetic retinopathy should be seen by an ophthalmologist. Otherwise, intervention is required for vision threatening diabetic retinopathy only.
Yes. Patient with diabetic macular edema and proliferative diabetic retinopathy, they need intervention. So
Yes.
the third question is still clinical question. How would you manage a diabetic patient with coexisting hypertensive retinopathy? What do you prioritize?
So basically, there are risk factors for development as well as progression of diabetic retinopathy. One is hypertension. So the one thing is diabetic profile, and you have to discuss with the physician who is taking care of the patient. Hypertensive retinopathy is known to increase the risk of progression of diabetic retinopathy. So the systemic control of blood pressure should be tight. It has to be tightly controlled because it's one of the risk of progression, the risk factor for progression, as well as for the onset of diabetic retinopathy, and both has to be treated. In relation to the hypertensive retinopathy, the only treatment is just controlling the systemic hypertension, and if there is other like lipid profile should be seen. And regarding diabetic retinopathy treatment, as we have seen, as we have said, vision threatening diabetic retinopathy should be there, but obviously systemic condition should be well controlled. Not only the hypertensive retinopathy, but also the diabetic nephropathy can also worsen the progression.
Okay. So I see some hand from Daniel Balai. If you have any question, you can raise. Okay, I have other question from chat box, Dr. Destaw. Among all the early findings, which one best predicts the patient will progress to proliferative diabetic retinopathy?
Basically, I mean, it depends on the stage of the
Stage of
the diabetic retinopathy. If it is severe non-proliferative diabetic retinopathy, the likelihood of progression to proliferative diabetic retinopathy is very high. So the stage matters. Otherwise, if you do fluorescein angiography, if there are ischemic areas, and then that's a telltale sign for further development of this the proliferative or advanced diabetic retinopathy. But we clinically we don't do fluorescein angiography, so the stage is the most important thing. That tells you how the progression can go through.
The other question is it possible to take high quality picture from cloud uploading and AI screening in remote areas, assuming there is a good connection, but no skilled ophthalmologist? So I think you can react on this.
Yeah, a good quality picture is very, very important for the AI to perform. So how you increase the quality of the picture, as we have discussed, one thing is patient should be cooperative. You have to clearly explain the patient how they when they are sitting while taking the fundus photo, they have to be cooperative. And the other thing is, I mean, if the picture quality is not good, you can dilate the patient. So you can put dilating drops, and you wait until the pupil dilates, and then you can get good pictures. And usually, if you want to improve the field of the fundus photo, is also one of the factors where you have to take two field photo, one disc center and one macular center. If you take two photos from the same eye, then it will improve the quality of the image and hence the performance of the AI. Did I get
So
your question?
yeah, I think yeah. But in general, for if you get high quality image fundus photo, you can do both teleophthalmology or you can do artificial intelligence analysis, deep learning analysis.
Yes.
So I think before going to like artificial intelligence, we can start with teleophthalmology, having fundus cameras at primary health facilities at primary hospital, then collecting image from those center and send back to the centralized image analysis. So we have another question from chat box from Tedros Adunya. Wouldn't there be few missed patients by analysis of macula and disc center photos as compared to the this is as compared to 9 quadrant fundus photo? So you can react, Dr. Desta.
Yeah,
Doing
basically,
only disc centered and macula centered imaging.
what really happens in the real world is diabetic retinopathy. It usually involves the posterior part of the fundus. But there are atypical features of diabetic retinopathy where retinopathy lesions can be seen in the periphery than the usual and at the posterior pole. So patients can be missed as a standard. These two pictures, the disc centered and macula centered pictures are good enough. That's why we are talking about the performance of like more than 98%. But we cannot say that patients can be missed, and that is where the medical legal considerations come into place. Because there is a chance that patients can be missed.
Yeah. Yes, patient can be missed. There is what you call predominantly peripheral lesions. Okay, we can have
Yes.
peripheral lesion in diabetic retinopathy. So the other is how can we in Ethiopia need to integrate AI in health system in general? I can react. So AI has subset machine learning and deep learning. We can start from machine learning. We can feed computers with high data so that we can recognize patterns from those data and use for screening, diagnosis, and prognostication. So in Ethiopia, we can start from machine learning. I think you can react, Dr. Desta, on this.
I think, these endocrine centers where there is a lot of diabetic patients, they have to invest also. They at least they need to have a portable fundus photo uh, camera machine or any kind of fundus photo. And they can also generate money, and at the same time, patients will be benefited. And I think we ophthalmologists should not waste our time seeing no diabetic retinopathy or mild diabetic retinopathy. Rather, we have to spend our time seeing more patients requiring treatment. So many of the things can be dealt in the local diabetic clinics, and I strongly recommend them to have these tools and use either teleophthalmology or AI. And it's a big initiative from our AI department in Ethiopia also. So I think the thing it's a real time. So to do all these things.
Okay. So the other question is from Dr. Kafle. In our setting where patients present late, what is your practical threshold to initiate treatment in non-proliferative diabetic retinopathy? So when do you treat non-proliferative diabetic retinopathy?
I think this question is raised from maybe from ophthalmologists. I don't know. So uh, it depends. I mean, there are a lot of factors that you need to see, especially let's say the location where the patient is coming from. Studies have shown that if the patient is not able to attend, okay, Then you can start doing laser treatment for severe NPDR, starting from severe NPDR, or if the patient's systemic profile, if the sugar control is not really good, then you can also consider. And if the patient's renal status is not good, because these things are very important for progression, then you can consider doing. And if the patient is not mentally healthy, I mean that in a sense, if you think that the patient may not come in time, then you may initiate a laser. This is about laser. And if you ask me about the role of anti-VEGF, I think in 2025, basically we give anti-VEGF for either for proliferative diabetic retinopathy or when there is macular edema. But FDA has approved, American FDA has approved the role of anti-VEGF for simple non-proliferative diabetic retinopathy, just to reverse diabetic retinopathy and to decrease the risk of progression, which is not practical in our real time in our clinics. That is the thing. So there are a lot of things to be considered.
Yes. So for severe non-proliferative, we can do pan-retinal photocoagulation for patients from far areas, patient with renal failure, patient with comorbid disease, patient who lost one eye because of diabetic retinopathy, pregnant mothers with severe NPDR. You can do pan-retinal photocoagulation. So the other question is, if tight glycemic control is protective, how do we explain the phenomenon of early worsening of retinopathy after rapid glucose correction?
So rapid glucose correction can worsen the diabetic retinopathy. This is one of the factors. So if you see, for example, for like a patient with soft exudates, like that means infarction of the nerve fiber layer, that might be because of sudden control. Okay, that has to be weighed against the role of this controlling the systemic control. But as you have said, tight control rapidly can for some time can worsen the progression. But then we strongly advise like the patients to have tight systemic control. And sometimes patients in the clinics, patients can tell you that, oh, my sugar is like in the normal range, my sugar is like this, and they don't know how the sugar is fluctuating. Okay, studies have shown that the sugar should be kept in normal range at least 70% of the time, and they tell you my average is like this. But if the sugar is fluctuating, that is one of the issues. And there is also metabolic memory, where the patient, the cells remember how stressful the glycemic control was before, and these patients may have normal glycemic control this time, but because of metabolic memory, the progression can still happen.
Okay, the other question is from chat box. Thank you. What is the place of smartphone fundus photography in reaching peripheral medical centers? Smartphone fundus photography, using a smartphone for screening purpose.
I think that is the future of AI, where patients can take their fundus photo for themselves. There are reports like a smartphone photo. There are studies, I mean. That will be like the most ideal thing, because these patients, they don't need to go to the local eye health center, and they can take their photo, they apply the fundus photo on the AI model, and they can themselves know. I think the trend of the AI is going towards that. That's what we wish.
Okay.
But the lightweight model that we which is developed, as I explained before, is also for the edge devices, like portable fundus photos and smartphones. The problem is you need to have still that fundus photo taking machine.
The other question is from South. Is neovascularization in proliferative diabetic retinopathy purely maladaptive, or could it be interpreted as a compensatory response to ischemia that become pathologic?
Yeah,
It's more,
perfect.
yeah,
Perfect.
it's compensatory, but the response is uncontrolled, so that it results in retinal tractional detachment, vitreous hemorrhage, and the like. Is it not practical to make AI screening on fast track in our country? Is it not practical to make AI?
I think you can reflect on this. So, I mean, yeah. So what matters is the cost, the readiness, our understanding, the awareness. So we can have a lot of models locally, but it all depends. So it's very difficult how fast we can have all these things in time for our patients.
How can we continue on safety in AI?
So the medical legal considerations, a lot of things to be considered. At least if you, at least you know, if you are using this model, then it has to be like FDA approved. I mean, the local FDA also should give and register that software as a medical device for diabetic retinopathy screening. Otherwise, it's one of the concern always.
But we shouldn't afraid of artificial intelligence. It will help us a lot.
Yes, definitely.
Because nowadays there is this phobia of artificial intelligence, but if you know how to use it, it will help a lot. So I think if we have finished all the question from chat box, and if there is any question, we can accept.
Any more questions to be addressed?
Okay, Mangistu, you can ask your question.
Thanks, Dr. Desta. Would you make your primary dataset in segmentation format, since it is better than classification, and you compared lightweight mobile model with other state-of-the-art primary on what was the common criteria to compare? So to reflect on this, so there are performance measurement parameters. Okay, so based on those parameters that were used by the state of the art AI models with as compared to the lightweight model that was developed here, the performance was compared based on that. That's how normally it's compared, like based on the precision, accuracy, Reander curve, and all this comes from the parameters of the training. most of the questions looks like more of non-AI related, more of clinical. What factors
Yes.
determine? What factors determine visual recovery after treatment? I think this itself is a topic by itself. It's one of the big. It can be one topic itself. So a lot of factors. So the clinical profile, the clinical stage of the disease at presentation can be one of the things. The amount of ischemia in the macula, and whether the clinical presentation or whether it is advanced stage or not, whether there are comorbidities. We can talk a lot of things on this. So a lot of factors.
Yes.
And I'll take the opportunity again to like talk you regarding the screening criteria. Please, please. I think there's a background noise. So please don't forget the screening criteria for diabetic retinopathy for type 2. Type 1 is like for type 2 it's at the time of diagnosis, and for type 1 in 5 years from diagnosis, and for pregnant patients pregnancy we have to do screening in the early conception or first trimester. Okay, these things are very important because we are clinically we are seeing in our OPDs we are seeing a lot of patients coming with advanced diabetic retinopathy.
I was mute. I think we have finished questions from the chat box. Mulgita, is there anything?
Thank you, Dr. Destaw and Dr. Jibat for your excellent presentation time, and participants for your patience. Now you will get your post-test on the chat box, and I invite you to join us in the afternoon presentation that will resume 3 to 5 p.m. Thank you, Destaw, and also Ophthalmology Society. We appreciate your collaboration with Emma. Thank you.
Okay, thank
Thank
you.
you very much for giving us all the chance. Thank you. Really appreciate it.
ማክሲመም 100 ስንት ነው የደረሰው?